So why do we sleep? We sleep because sleep restores. This is one theory. There's many theories, but the theory that's getting the most press these days is sleep restores and repairs what's lost in the body when we're awake. So emotions, cleaning out clutter, managing sensory overload. There's a lot of emphasis right now on sleep and how sleep does these wonderful things to restore the brain. And this is very relevant to autism because people are now feeling it's a disorder of overconnectiveness or hyper arousal. So one of the reasons that sleep may help our kids with behavior during the day is because of this restorative theory. This is an example of the biological. And then what are some of the consequences of not sleeping? There's a very big literature in typically developing children, particularly with sleep apnea, where if you have sleep apnea and your sleep is disrupted, you can have ADHD type symptoms, attention deficit hyperactivity symptoms, and when you treat sleep apnea with adenotonsillectomy, it can help the ADHD symptoms. So that's the model that we've used, even though kids with autism don't necessarily have a lot of apnea. They may have some, but it's not necessarily more prevalent than in the typically developing population. But there are clues that this not sleeping well can contribute to more problems during the day. Schreck and al. Had found that short sleep duration was associated with greater autism symptoms. Again, this is chicken versus the egg. Maybe it's not that the sleep problem is causing the autism symptoms entirely. It may be that the autism symptoms are contributing to the sleep problem, or that something is driving both. Gabriel's found that the presence of sleep problems was associated with repetitive behaviors, although this effect appeared mediated by nonverbal IQ. And then Du and Wing, using the Parenting Stress Index short form and the CSHQ, showed that the presence of sleep problems was associated, not surprisingly, with higher levels of parenting stress. So how do we develop standards of care? This gets to that practice pathway I mentioned that we developed in the Autism Speaks Autism Treatment Network Sleep Committee. And it's for the surveillance, the diagnosis, and the treatment of insomnia in ASD. And the surveillance diagnosis part is where healthcare providers ask families about insomnia and review targeted questions from the CSHQ. And then the specialists also address potential medical issues that may be contributing to insomnia and refer as needed to a medical or sleep specialist. The treatment part, we always start with the behavioral as a first-line approach, and we'll talk about why that is later. But autism specialists and their team will then provide the family with behavioral sleep education, and that's the part we're still working through. Sometimes it's a book, like the book we're going to be publishing, or other books that are available out there already. Sometimes it's a pamphlet, like the pamphlets you've picked up today, and sometimes it's an intensive session with a behavioral therapist or a nurse in the pediatrician's office. And then plan B is if the behavioral approach doesn't work, we will use medications in conjunction with behavioral therapy with referral to a sleep specialist as indicated. So this is a busy slide, but I was able to break it into a few different parts. So the screening part, you might find it small in your handout. The screening part is basically looking at whether the child has any symptoms of insomnia. And there's some numbers in here, B6, B8. Those just refer to the CSHQ. But the important thing for you to know is it's asking the parent specific questions about how long does it take your child to fall asleep, night wakings, are they co-sleeping, which could be a cultural preference, but in a lot of kids with autism, parents are co-sleeping out of necessity. They're worried their child is going to wake up. They're worried about safety issues. So we ask about those kinds of things. And then that's the screening part. And then in the second part, we assess and treat. And there's two parallel paths, as you can see here. One of the paths is the, let's see if I can put the mouse on, and I think that works, yeah. So one of the paths is the whole medical contributors path. Are there medical contributors like GI problems, sleep apnea, and that can be addressed and treated. And then the second path is the insomnia toolbox, or the sleep education path, the toolkit path. And that's assessing whether the family is able and willing to use an educational approach, initiate sleep education, and then either follow up with the practitioner or consider consultation to a sleep specialist if the family is unwilling and unable to use an educational approach. And that might be where medications come in, or a more intensive behavioral program. And then the next one, which is equally important, is the consulting and referring to other providers as needed. And then, if the insomnia is resolved, you're done. But if it's not done, and you've made these consultations, and you've considered sleep medicine, you've considered a referral to a sleep specialist for insomnia, we follow up. We make sure that we circle back, that the family is doing better. And if they are, you're done. But if they're not doing better, you go back and you try to assess, did I miss a sleep problem? Do I need to do a sleep study? What's going on with the family? So this is what we came up with, and it unfortunately is not based on lots and lots of data. It was more of a consensus because the work and the data are just not out there yet. I mean, what we really found was that there were no Food and Drug Administration, the FDA, drugs for insomnia. We were really going with a lot of empirical or consensus-based advice, and flexibility is obviously the key. And as I mentioned, the follow-up is really important. Essential to follow up with the family to see if the sleep intervention you've put into place is effective. And if the child is not responding, consider consultation, referral to the sleep specialist, consider a trial of medication for sleep, be sure to follow up the children, and then consider repeating everything in another year. And then the screening, these were the questions that I mentioned earlier: falling asleep within 20 minutes after going to bed, falling asleep in a parent or sibling's bed, the child sleeping too little, the child awakening during the night, as well as other screening questions that get at some of these medical comorbidities like snoring. And other sleep questions could be used as well. So this is one. This is the Children's Sleep Habits Questionnaire that's in your booklet, and we're going to have some of you fill this out over the break. It's 45 items. The subscales are listed here. And the parent basically lists whether for each item, how frequently is it occurring, and is it a problem or not? So using the is it a problem or not, it's very easy to just scan through and say, okay, these are the things that the parent is most concerned about, and then address them. But it's important to realize there are other sleep screening questionnaires out there besides the CSHQ. This is the BEARS. B is for bedtime problems, E is for excessive daytime sleepiness, the A is for awakenings during the night, the R is for regularity and duration of sleep, and the S is for snoring. So this in some ways may be easier, particularly for a practitioner to use, just kind of off the tip of their tongue, because they can remember the mnemonic, the BEARS. And then this is a completely different type of sleep questionnaire, but complements the work of the Children's Sleep Habits Questionnaire, or the BEARS. It measures sleep hygiene. It's called the Family Inventory of Sleep Habits. And it asks, here I'm showing the 12 questions that we used kind of in our validation study, but the one that is in your book is longer and asks even more questions. And asks about exercise, asks about the consistency of the wake-up time, asks about stimulating activities or relaxing activities before bedtime, asks about caffeine. So again, the practitioner or the parent, if you're filling it out, can get a quick assessment of what areas the child potentially could be worked with or trained in to help sleep. And then sleep logs or diaries are also oftentimes very helpful as well, because they can actually chart out when a child is asleep, when they wake up, and give the parent a really good visual that they can then discuss with their healthcare provider. So I'm going to stop here and see what questions you might all have.